Well, good evening, everyone. It's just past 6 o'clock, and welcome again to all of you joining us for the Wednesday evening webinar. Today we have a really relevant topic, an update on abdominal wall surgery, particularly as it pertains to hernias. And we have an excellent faculty that has been brought together by Dermot Hare, and I'm very grateful to Dermot and our speakers for joining us this evening. We will be joined by Sean Johnson, who is a colleague of Dermot Hare's in the Midland Regional Hospital in Tullamore. Also by John Keneally, who is a surgeon at the Mater Hospital, Dublin. Christina Fleming, who is currently a colorectal fellow at the University Hospital in Bordeaux and chair of the Irish Surgical Research Collaborative. And we are finally joined by Liam Horgan, who is a fellow of the college, but is also chair of the British Hernia Society Registry Committee and a past president of the British Hernia Society. So Liam, you are extremely welcome. Most of you will be familiar with the process. We would ask that you would turn off your cameras if you're not actually contributing to the meeting. And secondly, if you mute your microphone so that we don't get feedback from the background noise. So we'll be very looking forward very much to hearing this webinar, and I'll ask Dermot Hare to take over. One last thing, that if you have questions, we'll take these at the end, but please do use the chat facility, which is at the top of your screen. You can type in a question, and both Dermot and I will be keeping an eye on the chat section to see if we can fit in questions at the end. So Dermot, thank you for organising it, and I look forward to a very interesting evening.
Thank you very much, Professor O'Connell, and good evening, everybody. You're very welcome to this webinar. We have an interesting group of speakers. I think really nobody needs any particular introduction. As you know, and as we've said many times, hernia surgery has kind of been attributed less attention than sometimes than it might deserve, and that goes on. Just this, in the last few weeks at the European Hernia Society, there was emphasis on
sorry, Dermot, somehow you've gone mute.
Okay. As I was...
all good now, thanks.
Was I muted from the start or no? Not sure.
No, just something happened and you went mute, so we're all good.
Okay. Anyway, at the EHS in Copenhagen just recently, the European Hernia Society were focusing on rectus diastasis, and at the end of the meeting, there was actually difficulty in deciding what rectus diastasis is. Just in the last few hours, I read a piece in the Hernia Journal, which is the World Journal of Hernia Surgery, and there is debate at the moment whether there is any major difference between placing a mesh intraperitoneally or extraperitoneally. The bottom line of all of this is, even though there's a lot of hernia surgery about, we really don't have a lot of answers. So I will get the ball rolling. Sean Johnson, who's the Director of Surgical Training and a colleague, is going to speak initially. Sean.
Thank you very much, and thank you, Dermot, and thank you, President and Vice President, for organising this and asking me to speak. So hopefully we'll start. That's my screen is sharing. I hope everyone can see that. Presume they can.
It's perfect, thanks.
Yeah, okay, so just a disclaimer, because this might have caused a bit of confusion. This isn't actually a website, but it does bring us to really, you know, what hernias have often been looked at is what's really the issue, why it's only a hernia, who really cares, and where's the real stuff to do. And that's really hopefully what I want to try and deal with shortly today. So what's the issue? Well, 20 million surgical hernia cases worldwide per year. That's significantly higher than a lot of other major surgeries that are performed. And one of the problems is the recurrence rates are really varied, dependent on hernia type and repair, and range anywhere from 2 to 40%, which for many other types of surgery, if you had that sort of poor results, everyone would be wondering why you're doing it at all. And when we look at surgical site infection rates for hernia surgery, again, there's a huge range of infection from 0.7 to almost 30%, with an associated mortality from what is a benign quality of life surgery often of 3%, which is, you know, again, very high. And if we look at the United States alone, that costs $3.3 billion a year in complications post this surgery, with an extra 1 million inpatient days. And finally, our outcome data worldwide is still very poorly recorded, and I think Liam will deal with that hopefully later on. So why it's only a hernia? Well, fortunately, we do have some definitions from the European Hernia Society when we're dealing with primary wall hernias, and really they can be broken down to either midline or lateral, and defined on size. Small being, you know, very straightforward, less than 1 centimeter, and a lot of them wonder whether they need to be repaired at all. But it's more the medium and the large, really, that a lot of the questions will be discussed. And with regards to incisional hernias, again, the EHS has come up with a good classification, really looking at position, again, either midline or lateral in various different positions, whether they're recurrent incisional hernias. And I think this is a big issue when you get into a scenario of repeat operations, and it creates a lot of problems. And what the size is, and again, the size has a significant bearing, I think, on what you do and who should be doing it ultimately. These are really two CTs of relatively straightforward incisional or primary hernias. They're small. They're, you know, 4.5 to 5 centimeters in width, and generally most people, well-trained general GI surgeons, will deal with these with a number of different techniques, and they're not really a problem. I mean, they'll come together without any major adjuncts and with reinforcement, so they're not really an issue. This one is slightly more of an issue in that it's a lateral wall traumatic incisional hernia that we repaired recently, and this unfortunate lady had an RTA and had a number of attempted repairs with recurrence. So by the time we got to her, she had a lateral wall hernia, which had been attempted at least 2 times before we got our hands on her. And this guy is one of the big issues that we often see, and I'll just play it briefly. But he has a very large, massive incisional hernia, again from multiple previous surgeries, and as was very kindly referred to us just for review, and he's going to require a number of adjuncts, which I'll discuss briefly later on, but it's certainly not a simple, straightforward hernia repair. And this guy, obviously, again, we referred recently, while it's not a ventral, this is a giant inguinal hernia with significant loss of domain, and most of his midgut and hindgut is in his scrotum with a fair bit of ascites, and this guy is going to be significantly difficult to manage. But it's something that does need to be considered because his entire life is on hold. He can't move, he can't walk, he can't do anything. So it does need to be considered. You can't just say, no, we're not going to even attempt this. So who should we operate on? What is the right operation, and who should operate on what? And this is what Dermot had asked me to kind of talk about a little bit. Well, what's important? What do we need to manage? Well, obesity is a big issue. Most of the people we're seeing have high BMIs, and high BMIs radically increase wound morbidity, radically increase recurrence rates, and it's independently associated with increased nosocomial infections, readmissions, and postoperative transfusions. So controlling and getting weight down is critical before you'd even consider taking on some of the bigger hernias. Obviously, ASA grade 3s or greater is going to increase risk, and advanced age are all areas where one has to really look at and try and, as much as possible, improve before you'd start taking on some of the bigger hernias. Smoking cessation, absolutely, because we all know that there's 2 times more likely level of recurrence if they continue to smoke, and they have twice as much chance of getting wound complications after surgery, and wound infection being one of the biggest issues for what is most part quality of life surgery. It's not a malignancy. Control of diabetes and eradication of MRSA or any other infections that the patient may have prior to undertaking the surgery. What's the right operation and what options for repair? Well, the main principles I think everyone will agree on. It should be tension-free. It's not always possible, but it should be. You need to return the abdominal wall to the abdominal anatomical state as much as possible, to the pre-morbid state. And I think most people would now agree that for anything over a centimetre, reinforcement of the abdominal wall with some sort of prosthetic is probably recommended. And really try and avoid bridging operations where you don't have the fascia closed. And the general surgical approaches, I mean, there's always been open repair. Laparoscopic repair is becoming increasingly popular, but is technically harder in many respects. And then laparoscopic robotic repair, obviously with the use of robots, that probably does help. And I know John will talk about that, so I'm not going to stay much longer on that. Who should do what? And this is what Dermot, well, I think every GI surgeon should be well able to do and have in their armory the ability to do lap IPOM plus, and that's what I mean by that is no bridging and closure of the anterior wall, the anterior fascia defect. I think everybody should be trained to be able to do an open reeve stopper repair. I think that increasingly is becoming the gold standard for ventral hernia repair, certainly when they get to 3, 4, 5 centimeters plus. And then there are some other laparoscopic repairs like LIRA and so on, where you can do a posterior aponeurodectomy to close the posterior layer and reinforce that. Where it becomes more specialized and complex is where you get incisionals, large incisionals, non-midline, and very large primaries. And you have a whole myriad of techniques which do require obviously an interest, and I think is where you're getting into the realms of someone taking a special interest in this type of repair. And they include all the various laparoscopic, robotic, sugar baker type repairs for peristomal hernias, and then complex adjuncts such as Botox and progressive pneumoperitoneum for patients who have loss of domain, and obviously operations like transverse abdominis release. So where are we with recommendations? I think laparoscopic techniques have a lower recorded surgical site infection rates than open. For open repair, I think reeve stopper should be performed rather than an on-lay procedure. Transverse abdominis release should definitely be prepared, in my opinion anyway, to anterior component separation. I think if done properly, there's significantly less complications from it. Adjuncts such as Botox injection may well decrease the need for TAR, which obviously is a damaging technique in its own right. And definitely more work needs to be done on what mesh type is the best procedures to be done, our outcomes, which we don't have good data on to really at the moment. And that's both on research and national data, and on hernia prevention. Definitely from the point of view of incisional hernia, I think a lot more work needs to be done, like the STITCH trial, on preventing incisional hernias in the first place. And then finally, setting up departments well, using preoperative scoring systems to help to identify the patients that we've previously seen that are at significant risk for morbidities. Finally, if the idea is to prevent the problem in the first place, and if you can't prevent the problem, you need the right equipment, you need the right patient, because without that, you're going to continually run into problems. You think you've done the right operation, and then you get a recurrence, and that just makes matters worse. And then you get another recurrence, and you try another operation, and that fails, and you're into doing more and more difficult operations with increasing morbidities, with increasing likelihood of recurrence and failure. So ultimately, I think try and prevent try and do the right operation first, and try and pick the right patients. That's ultimately what really is the only the message I want to get across this evening. Thank you very much.
Thank you very much, Sean. Thank you very much for covering that. I'd like to go on to the next speaker is Mr. John Keneally from the Mater Hospital. John doesn't really need any introduction, and John is going to speak about use of the robot in abdominal wall repair. Thank you very much, John.
John's having difficulty sharing his file, so if we could move on to the next speaker, John will come in afterwards.
I'm running out to buy a non-Mac laptop. Give me a few minutes.
No problem. I'm with you on that one. Just while, the next speaker is Ms. Christine Fleming, who is at the moment has completed her Irish training and is a robotic fellow in Bordeaux. Ms. Fleming is the head of the International Collaborative Research focus for this country, and this is an up-and-coming group of young surgeons who really deserve a lot of attention. For example, just while she's getting set up, and thank you for coming in early at this, Christine. Just for example, if somebody has a contaminated procedure and they have closure of a laparotomy. So if somebody has, for example, peritonitis and we close the laparotomy, there's up to a 45% risk of getting an incisional hernia. If we walked into any other non-malignant group and said, look, we have a 45% chance that this operation won't work, you'd be sent running from the building. So there's a lot of work to be done in relation to some of the issues. So Christine is going to talk about some research that is going on at the moment. Thank you, Christine. And by the way, can I ask that everybody mutes their microphone at this time? Thank you very much.
Great. Thank you, Prof. Hare, for the kind introduction. Good evening, and thank you to the organisers for inviting us as the Irish Surgical Research Collaborative to present as part of tonight's webinar. So I'm going to speak a little bit about international collaborative research in the arena of inguinal hernia repair. Next slide, please. Great. So to explain fully our role in this area of research, I'll firstly speak a little bit about the ISRC, who we are, what we do, and then touch on two global inguinal hernia specific projects that we are involved in delivering. The first of these is Retainer 1. This is a global cohort study of practice trends with postoperative urinary retention as a primary endpoint. And then following on from this, Retainer 2, which involves development of a patient-reported outcome measure specific for inguinal hernia repair. Next slide, please. So I think at this stage, most of you will have had some contact with surgical trainee collaboratives, the first of which was formed in the UK in 2007 in the West Midlands. And it was formed as trainees recognised the difficulties in performing high quality research with the demands of training and frequent hospital rotations. So their aim was to deliver high quality, multi-centred clinical research with real patient benefit. And what commenced as small cohort studies has since developed into an ability to perform large scale, multi-centred international clinical trials and have the ability to impact on public and healthcare policy. Next slide, please. And here is a short summary of how we as the Irish Surgical Trainee Research Collaborative have developed over time, from informal discussions and designing our first protocol in 2015, to formally establishing a committee and launching our first study in 2017, receiving our first 2 successful grants in 2019. And after a short period of inactivity due to the pandemic, we have again gained significant momentum in 2021, most notably delivery of a global study in Retainer 1, and selection of the OAK trial, which will be a national clinical trial in metabolic surgery and delivered by General Surgery SPR Zara Kennedy in the new year. We are also currently developing a national QI project to focus on the perioperative management of obesity, which as a non-cancerous disease quite often is neglected in research priority. So next slide, please. So why is a surgical trainee research collaborative beneficial in Ireland? In 2020, the ISRC, in collaboration with the Irish Forum for Surgical Research and RCSI, performed some quantitative and qualitative work on research priorities and barriers to research and surgical training. And we received responses from 95 surgical trainees, both in the Republic of Ireland and the Northern Ireland Training Deanery, as the Irish Surgical Research Collaborative is an all-Ireland trainee representative group. And I think these three statements support why Trainee Collaborative has benefits. The collaborative allows access and opportunity to research for all trainees, regardless of stage of training, institutional affiliation, or geographical location. And over the past 7 years, since our inception, we've developed a mechanism and pathway for delivery of large national or international studies. Next slide, please. So it is accepted that working collaboratively, there is huge opportunity to complete high-quality patient-centred research in critical areas of surgical research priority. And currently, these 4 areas of an ageing population requiring surgery, preoperative care, emergency surgery, and obesity are at the upper end of the priority list. And we aim to touch on many of them in our next work following retainer. But when it comes to methodology and study design and formulating our outcome analysis, it is important that we bring it back to what is important to individual patients across a multitude of different domains, including clinical, oncological, functional, and also in a more holistic manner from the point of view of quality of life. Next slide, please. So considering these principles of creating a research environment that studies a common condition to allow large-scale surgical trainee participation and has an outcome that is focused on patient-reported outcomes, Stephanie Krogan, my urology colleague, pitched the retainer study at our study selection Dragon's Den in 2018. Next slide, please. As a urology trainee, Stephanie identified post-op urinary retention after inguinal hernia repair as a significant post-operative problem, particularly in male patients after a certain age, where prostatism may already coexist. And as general surgeons, we may not fully have perceived the impact of this on patients, as often if we discharge a patient with a catheter in situ following a failure of trial without, we generally might not see them again as they follow up in the urology clinic. So this multidisciplinary element of the work also had huge learning opportunity. And when it comes to post-operative urinary retention, the literature is very variable and really based on small sample size, low quality studies. And furthermore, when it comes to patients who actually are unfortunate enough to actually develop post-operative urinary retention, there's a significant lack of any patient-reported outcome data related to such issues also available. Next slide, please. So when trying to answer both of these questions, we have to decide on what is the best methodology. And often when it comes to interventions, non-RCT research can often be dismissed. And yes, it can be flawed, and often there are confounders that cannot be controlled for. But with solid methodological and statistical support in design and from the beginning, a lot of these issues can be overcome. And there certainly can be a role for both. Next slide, please. So consulting the ideal framework for study design, which everyone involved in surgical research should familiarise themselves with, it's a freely available tool and is now the expected standard of consultation for all interventional study design. I've highlighted 2 key questions. The first one is the therapy still evolving? So with regard to the therapy, we're talking about an inguinal hernia repair. And whilst the principal steps of performing an inguinal hernia repair, tension-free mesh repair, are the same, the tools and the techniques and the materials that we may use to actually perform the surgery are constantly evolving. And that may be from using sutures versus tacks versus glue to performing the surgery open, laparoscopically or robotically. So I think the answer is yes, the therapy is still evolving. And the second question, is the clinical community ready to perform a definitive trial against best current therapy? Well, we don't know what best current therapy is for assessing patient-reported outcome measures after inguinal hernia. So I think the answer is no. So it is suitable to perform this through a non-RCT based study design. Next slide, please. So ultimately, we proceeded with a global cohort study for Retainer 1, followed by a 3-phase evaluation and development of a hernia-specific PROM for Retainer 2. Data collection is now closed for Retainer 1. We have data on over 3,500 patients from all over the world, essentially. Next slide, please. It wasn't all plain sailing, however, and while the pandemic hit hard on the delivery of elective surgery, it also could hit quite hard on delivery of the retainer study. But we took this time to explore with the network of international colleagues that we had developed in designing and planning retainer, and we delivered a small piece of work exploring the impact of COVID-19 on elective inguinal hernia repair, which I'm sure most of you will recognise was quite harrowing at the time and is still in a state of somewhat recovery. Next slide, please. So here is an overall summary of the Retainer 1 timeline. It has taken us 3 years to get to this point, obviously not helped by the pandemic. Data collection is now closed, and we are commencing full data analysis with the Department of Data Science and RCSI at the moment. In late September, Stephanie Krogan performed an interim analysis of the first 1,000 male patients, and I'll present some of that early data here. Go next slide, please. And next slide again. Thank you. So all patients were male with a mean age in the mid-50s, a relatively normal BMI, I guess, and relatively low IPSS scores. Next slide, please. It's important to notice here that less than 50% of procedures were performed under general anaesthesia, but this cohort actually contained a lot of patients from lower income countries. This is an interim analysis and not representative of the entire cohort. Next slide, please. And in keeping with this, over 75% of cases were performed open. And again, I don't think this would truly reflect our final cohort either, and it's something we need to caveat when we're looking at these interim results. Next slide, please. So the overall postoperative urinary retention rate was 5.3%, and this led to an unplanned admission in 20% of cases. And in our final analysis, we really want to dig deep into the outcomes for these patients, the duration of catheterizations, the economic effects both for patients and healthcare systems, and explore quality of life and disease-specific patient-reported outcomes as part of the Retainer 2 study. Next slide, please. We also explored in this interim analysis, with the caveat that it is not the entire study cohort, so a lot of the statistical controlling that would be in place doesn't fully apply. But we aim to identify any risk factors for developing postoperative urinary retention, and in particular to identify any modifiable factors that could be addressed preoperatively. And we identified significance associated with high preoperative IPSS scores. Next, please. Undergoing bilateral inguinal hernia repair. Next, please. No bowel opening for at least 2 days preoperatively. Next, please. And undergoing an open surgical approach. But I think this is a type 2 error based on the fact that there is such a significant proportion of patients who underwent open surgery in this initial cohort. Next, please. Factors expected to influence, but that did not influence postoperative urinary retention rates included preoperative alpha blockers. Next slide, please. Perioperative opioid use. Next, please. Use of an in and out catheter, which I think was an interesting one, not to find any association with. And next, please. And finally, volume of perioperative fluids infused. Next slide, please. So following on from here, we have 3 clear analysis and publication priorities for this data. We really want to focus on postoperative urinary retention, but also explore overall global practice trends in inguinal hernia surgery, perform some risk prediction modelling, and analyse the impact of both patients and healthcare systems when complications occur, and are there interventions that we can create to create a more level playing field with regards to this. In parallel, we aim to commence Retainer 2 for developing a PROM in Q3 of 2022, and patients have already enrolled for this as part of Retainer 1, which included an opt-in, and we've submitted a funding application for this also. Next slide, please. So briefly, the structure of Retainer 2, it'll be a 3-phase study involving item generation, which has already been commenced by members of the research collaborative, who are Anya O'Neill, Liga Akumanke, Anna Fullard, and Ina Ryan. And this involves a systematic review of all outcome reporting measures in inguinal hernia surgery. Following this, we will enter into qualitative and quantitative pre-testing and PROM evaluation with multiple different patient groups. Next slide, please. So to summarise, I guess large-scale trainee collaboratives offer good opportunity to match the unmet needs of patients and the surgical trainees interested in research. And this can lead to delivery of high-quality research with real patient benefit. Studying common conditions is key for both inclusivity, but also the potential to offer maximum benefit to maximum number of patients. And finally, I think collaborating with international colleagues has been a really positive experience for us both individually and as an organisation. Next slide, please. If anyone would like to stay up to date with our work, we're on social media platforms or can be contacted at the ISRC at rcsi.com. And we have a website currently under construction at the moment as well. And next slide, please. The final slide. So thank you all for listening. And in particular, I want to send out a huge thank you to all of the members of the ISRC committee who've worked really hard. And thank you for your ongoing contribution as well. Thank you.
Thank you very much, Christina, for a great overview. Thank you very much, and you're to be congratulated, and good luck with all the inevitable research that's going to follow, and particularly research in relation to improving excellence in hernia surgery. John Keneally, are you ready to rock?
I think Liam will go next, if that's okay.
Yeah. Okay, so it gives me great pleasure to introduce my colleague in the BHS is Liam Horgan. Liam is an Irish graduate who works in the north of the United Kingdom. We met initially under difficult circumstances, and Liam has become an incredible supporter of Irish hernia surgery. He's the ex-chairman of the British Hernia Society. He came to speak with us at the Charter Day meeting some years ago, and since that time has gone out of his way to try and improve relations between Irish hernia surgeons and the British Hernia Society. And indeed, we need this at the present time. Liam has spent a lot of time recently in organising the registry, which he hopes to roll out over the next while. And really, I believe this is very, very important for hernia surgery in Ireland. And I think that we could not be in a better position to try and introduce this because of Liam. Liam, thank you very much for agreeing to speak this evening. You're very welcome.
Great. Thank you very much, Dermot. Thanks for that very nice introduction. And thank you to the organisers for asking me along. So I've been working through the British Hernia Society to establish and initiate a registry for hernia surgery. And you might kind of think, well, why are we doing that? A lot of you will maybe be colorectal surgeons. You'll put your cancer patients into a registry. The orthopods put their hips into a registry. The cardiac surgeons do the same. And yet it continuously amazes me that we as general surgeons do the most common elective operation, which is a hernia operation, and we don't put anybody into a registry. We haven't a clue what happens to them. And Sean earlier on mentioned about the different types of hernias and which ones he was more worried about. And he said, these are not really a problem. Actually, we haven't a clue whether they're a problem or not. We have no way of knowing. Yes, there have been randomized controlled trials on, for example, open versus laparoscopic groin repair, but nobody actually knows what happens over 5, 10, 15 years after a hernia repair. And as a result, we have multiple different approaches, multiple different techniques, but not one of us knows what happens to our patients. So we set about thinking about this and trying to work out what to do about it. I think a lot of us will be aware of the Danish hernia registry, which was established over 15 years ago now. And this is the only mandatory registry for hernia repair in the world. And they have been following their patients for those 15 years and have a much, much better understanding of what happens. They can look at it in terms of the type of mesh they use, the type of operation they do, the status of the surgeon, the type of patient, the comorbidities of the patient, etc., etc. So they're way ahead of us. And in fact, I know that in Britain and Ireland, we've been talking about a registry for 20 years and nobody has had the gumption to get up and do it. So one of the main aims for me in the British Hernia Society was to try and get this to happen. So I've had to take a very pragmatic approach about it. I could probably sit here and end up doing research for the next 10 years to try and decide what we should actually do. But in fact, I've decided we're just going to do it and then fine tune it as we go along. So could I have the next slide, please? So the actual aims of the hernia registry. Well, first of all, if we need to remember that what we're doing here is improving outcomes for our patients, so improving patient care, improving patient decision making. So that might mean being able to tell a patient, for that particular patient, what is the best repair, what is the best mesh, what their outcomes are more accurately going to be. We have no idea of, as I mentioned already, benchmarking our repairs, our standards, our meshes, and this registry hopefully will allow us to do that. So we'll be able to monitor what we do in real time, and we'll have regular reports from the registry which is looking at all these different factors. The registry obviously will be a fantastic source of research opportunity. And we hope to get a couple of research fellows going next year on the registry, but we'll be able to look at hernia repairs and outcomes based on the type of patients involved as well as the type of repairs. So there's a huge opportunity here for us as general surgeons to get involved in this and to actually know if what we were doing makes a difference. Next slide, please. So how are we going to do it? Well, this is a diagram really of what we're talking about. So first of all, we're going to ask every surgeon to record every hernia they do into this registry. That's a very grand aim, and in fact, you know, we are going to start gently and see how we go. But there will be a central digital repository for every single hernia that's done. We will be able to communicate with the surgeons by using a dedicated website. For example, they'll be sent emails to remind them to complete the data. They'll be sent individual reports. They'll be sent patient reports as well. Probably one of the most difficult things for us is trying to link the registry with the patient demographics that are available, for example, within the NHS or the Irish health system. So there's a lot of data stored in what's called the NHS spine, which is a digital spine, basically. And trying to get access to that is one of our main aims. And we've succeeded to a certain extent, but it is very difficult from a governance point of view. And of course, again, the most important person in this is the patient and the patient's outcomes. So we will be contacting the patients on a regular basis with their permission, and every patient will have to be consented when they're consented for their hernia operation. And we will be tracking them as long as we possibly can. And you might ask, well, what outcomes are you looking for? Because notoriously in hernia repair, hernia surgery, we actually don't have an agreed set of outcomes, although there are quite a few groups working on this at the moment. And the BHS has sponsored some research into this as well. But we are starting off with basic outcomes that the BHS will decide or has decided. And then as we go along, we will fine tune them. So tracking those outcomes can be done either by text, by email, or by an app. So an app is all the rage, and we are actually developing an app for the patients who can enter their information through the app. The app will also provide the patients with patient information, and running up to an operation, say an abdominal wall reconstruction or something, it'll be giving them lots of different information about exercise, about nutrition, advice about smoking, their diabetes, etc., to try and optimize their condition prior to surgery. So there's some benefits to the app as well for the patient. So it's not just about asking them for information. The power of this registry is going to be the numbers in it. So in the UK, there's probably about 100,000 hernia operations done every year. And it's one of the biggest, it'll be one of the biggest registries going. The Danes, for example, have 6 or 7 million population, so they have a much lower number of hernias in their database. So rather rapidly, I'm hoping that we will get to a very high number of entries into the registry, and we'll be able to get to some meaningful data pretty quickly. And again, you know, this is a registry. This is about recording and measuring what actually happens in the real world. So it isn't about somebody saying, oh, I do my hernias this way, I've never had a recurrence, all my patients are happy. This is actually going to ask patients what's happened to them. They will be asked if they had a recurrence, and then they will be you know, checked and examined as appropriate. But this is real world data, really. It's not an RCT or anything like that. The main aim eventually is to get to a mandatory status. So in other words, we would like to make it mandatory, you know, after a period of time, that every single hernia repair, from groin hernias to abdominal wall reconstruction, is included in the registry. And that, of course, means both private and public operations. So that's very important to us. Excuse me. So to do this, we've had to raise money, and we're in discussions with Dendrite, which is a database registry company. We've put a lot of work into it over the last 18 months, but we are making quite a bit of progress at the moment. So we have raised a significant amount of money, over 100,000, and we're aiming for 150,000 to give us a bit of leeway. And we are literally about to commission the database in the next 3 months. The results from the database will be published as reports, and there'll be an annual report and then individual reports. So any surgeon who enters data into it will be able to push a button and get their own individual report instantly. So in terms of validation and governance and everything else, you'll be able to get your reports. Next slide, please. Of course, that slide you've just seen, unfortunately, chopped out Ireland, which isn't much good as far as I'm concerned. And I would be very delighted if we could get the Irish surgical community to back the registry. That would give us a bigger population. All of us would then know how our patients got on. And I think, you know, we'd be very keen. I would be very keen, and the BHS would be very keen if we could work together on that. The database is the registry is able to differentiate between different countries because of different unique identifying numbers. So we have NHS numbers here, and the Irish system as an individual number, and the Scottish system has its own number. So we can differentiate between patients that are put into the registry quite easily. But basically, we need the support of the Irish surgical community to do this. Even with that support, there are some hurdles to overcome in terms of governance and patient data. But we would be very keen to have a look at this and work with you to try and make this happen. Next slide, please. So what are the steps and what have we had to go through? Well, basically, the first important step was that we decided that we would use the format of the Danish registry to start with. They very kindly translated into English because my Danish is rubbish. And we actually trialed their database in English in my local trust, the Northumbria Healthcare Trust, to see if it worked. And it did work. And my group of surgeons up here were quite keen to get their patients into it. So that was the first stage. So we've actually done that. The next stage was to raise the money, and we've now actually raised the money. So we have passed that stage, and we're on to the stage of building the actual registry. The BHS set up a subcommittee, the registry subcommittee, to look at this, and we have 5 very enthusiastic surgeons who are working extremely hard, putting in a lot of hours to make this happen. And we meet once a month, and we've made a lot of progress. We've made a lot of connections with lots of other groups, with the colleges, with the specialty societies to gain support. And we've also obviously been in touch with industry to raise money as well. But the next step include starting the registry off with the board members of the BHS. So there are about 13 of us in total, I think, or thereabouts. And the hospitals belonging to those board members will be the first hospitals that take up the registry. And we'll run it for at least 3 months and maybe 6 months, so that we can assess how it's doing, and we can fine tune it and change things and everything else. The governance of the registry is very important, and working with Dendrite, which is the registry company, they have a huge amount of experience here, and they've been guiding us on the governance issues. They actually manage at least 200 other registries, so they have, as I say, a vast amount of experience, which is very reassuring for us. But for example, we've had to look at things such as indemnity to make sure that there's no issues with data loss or anything like that. The next step then would be to extend the registry to all BHS members, and that includes Irish members, if we can agree a way of doing that. And finally, one of the big steps is to agree a national funding model in the UK and Ireland. So in other words, the startup of this registry is being funded by industry, but the idea really is that we shouldn't have to depend on industry. And we are looking at different funding models. For example, it might be that every single hernia operation that's done and a mesh is used, that one single euro or pound is actually put into the registry. So there's different ways of doing it. The final few steps then would be to extend it across the whole UK and Ireland. And the final step is to make it mandatory and include private hospitals. So it's an ambitious plan. It'll be the biggest registry in terms of general surgery that we know of. Next slide, please. But I think it really, it's something that we as general surgeons have to do and have to look at. So one of the reasons we have to do this is not just because we know it'll improve patient care, but because of the mesh debate that we're all extremely aware of. Obviously, with the gynecological mesh problems and even the hernia mesh problems, we have to be very open about that, and also we have to show that we're actually concerned enough to do something about it. So although the registry wasn't put into place just to deal with the mesh debate, it's actually a great tool for us to say that we're taking this extremely seriously and that we will build up the data about the mesh. So this is just to give you an example of some of the database slides. So this is the ventral hernia database. So it's not the way it's not the final version at all. This is more or less the Danish version translated. But the point I wanted to make is that it's not going to be onerous. So you should be able to fill this in less than 2 minutes per patient. There's a lot of drop-down lists. There's a lot of lists that disappear if you click another box, and other lists appear. It's very simple and it's very straightforward. We ask for very, very basic patient demographics at the beginning. And if we can link into the National Health Service database or the NHS database, then we may even be able to import that. That's what we're working on at the moment. But my point is that it's very simple, it's very straightforward, and you should be able to fill this in very quickly. Next slide, please. This slide is a groin database slide, and again, it's just showing you have various different boxes to tick in. Whether it's recurrent, the type of hernia it is, the type of operation you do, the type of mesh you used, type of tackers or suture material, whatever. And hopefully it'll cover just about all known hernia repairs, although sometimes I'm not sure, there's so many of them. So when we were talking about this registry, we wondered what hernia should we include in the registry, and we've decided we'll go with ventral hernias, meaning primary ventral plus incisional hernias, groin hernias, parastomal hernias, because nobody knows what to do with them, and also divarication. As I think you heard Sean mention at the beginning, there's a lot of new work on divarication. So we'd like to know what people are doing with that and see if we can work out what's the best thing for it. So there'll be about 4 different tabs that we can go to in terms of hernia repair. And next slide, please. So again, where we are right now is that we're literally we're commissioning the database and extending it to the board members. And next slide, please. Next slide, anybody?
Catherine, are you sharing the slides?
Yeah, she should be. Brilliant, thanks, Catherine. So just to go back to funding again, because funding was always a bit of a problem, a bit of a minefield, because we have been tainted with association with industry in the past, particularly with hernia repairs and mesh repairs. And we actually wanted to stay as far away from industry as we could in terms of a registry. However, the basic facts are that we cannot raise that kind of money without going to industry. We tried for about 6 months and literally got nowhere. So we did resort to going back to industry. And of course, industry is absolutely keen to find out what's happening to their products. There's a new European set of regulations which have just come in, which show that they have to provide some post-marketing surveillance. So they have to be able to say what's happened to their products when they're put into patients, and they have literally no way of doing that. So that was a great leverage for us, and every company, all the big 10 companies have contributed significantly, and it's helped us get going. But as I said, in the long term, we'd like to get away from industry funding if we possibly could. The Lady Cumberland's report, which is looking into, amongst other things, the mesh debate, even suggested that we should take industry funding if we have to try and get registries up and running. And so that's what we've gone with. Next slide, please. So in terms of industry then, they will need information, as I've said, on their hernia repairs. They need to know what's happening to their products. We will be able to provide that information. We'll provide it in the form of an annual report. We can give them itemized reports about their products in comparison to every other product. And we will end up being able to basically sell the report once we get going after about 2 or 3 years. So we're hoping that this is one of the ways that we'll be able to raise funds if we can't do it any other way. So they have given us the pump priming funding. We have that now. We very much want to stay away from any allegations of corruption, etc. And the money is being held completely separate. It's not linked to the industry at all. There's no guarantees for the money. So we haven't agreed to do anything at all for these companies apart from give them annual reports. We tried to work through the Association of British Health Tech Industries, but that fell through in the end. That was to have a middleman to deal with the money, but that didn't work out. So the British Hernia Society is actually the one that's dealing with the money and is responsible for the money. Next slide, please. So what can we provide? Well, the kind of things that a registry allows you to do is to provide new product information. So if you introduce a new product, very rapidly you'll be able to work out what's happened to the first 100 patients if they're put into this registry. Now, there's no way we can do that at the moment. There's just no facility to do that. And setting up randomized controlled trials is great, but it takes a huge amount of organization, money, time, effort, and all the rest. And practically, it's not a very sensible way to do it. So we will be able to look at new products and focus on them early in their introduction. And we'll be able to look at all different operations, different products for different hernias, basically. So we will be able to focus on what's happening in the real world and report on that. Individual surgeons will, as I said, get their own reports. Probably just as important, they'll be able to tell their patients that they are contributing to the registry. And we will be conducting a publicity exercise, both for the public, but also for the surgical community to make sure that everybody does know about it. Next slide, please. I'm nearly there. So, so if it's going to be successful, we need everybody, meaning all the surgeons involved, to actually take part in this registry. We're trying to make it easy to enter data. Sorry. We're going to do it in a phased introduction, and we're going to provide as much help for surgeons as we possibly can. But as I said, the final aim is to have a mandatory input for this. Quality is important to us, and we will be looking at the accuracy of data input. We'll be looking at PROMs, which will be patient-orientated PROMs, and we have a subgroup of patients who are telling us what we should be collecting, for example. And obviously, there's a big research component to the registry, and we've got a separate committee looking at that at the moment. So we're conscious that everybody who puts something into the registry needs to gain something from it, and that means us, the surgeons, the patients as well. So we're looking at giving patients reports as well. And we need to be able to rather rapidly report on products or operations that have poor outcomes, so that we can extend that information across the community. And again, as I said already, security is very important. Next slide, please. So we have canvas support from a lot of our associations and specialty associations, including the colleges. I put the RCSI college up here. They have given us verbal support, and we're hoping to get more support from them as we go along. But most people that we talk to immediately come up and say, yes, this is a great thing. We should have had this years ago. How can we help? Sorry, we've no money. That's the next line. But anyway, so they are very keen to help. And hopefully this will allow us to encourage surgeons to enter data into the registry for us. Next slide, please. So this is the final slide. So, oh, missed one. It doesn't matter. Yeah, the next one. Yeah, okay, forget it. The last slide is literally just to mention some of the companies that have helped us. We put together a very glossy brochure to send to them, to explain the registry to them, and we spent a lot of time, getting help from them. The next phase, as I said, is now commissioning the registry, which we're doing right now, and then the next phase following that is commissioning the outcome work and getting that done. Realistically, we're probably looking at rolling out the registry in before Easter. That's what we're looking at the moment, and it could be as early as February. I would actively encourage everybody to try and push for the Irish surgical community to be able to enter data into this registry, and we'd be very keen to work together with anybody who wants to make that happen. Dermot and I have been working very hard on the BHS board for some time, and Dermot has been a great help to us and has opened a window into the Irish community, which is great. But we're very keen to work together. I would make a couple of final points. First of all, although it's called the British Hernia Society, anybody is welcome. I did suggest it might become the British and Irish, or the Irish and British Hernia Society, but we're waiting for people to say if they'd like us to do that. Joining the society is free, so join it as soon as the webinar finishes, and you'll have access to lots of guidelines and information as we go through. But thank you once again for having me speak.
Thank you very much, Liam. Thank you for an excellent overview. Just before we go on, by the way, anybody who has any questions, please put them into the chat and we'll try and get around to them. John, are we?
I think we're good. Can you hear me?
We can.
Fantastic. Okay.
And we can see you and you look great. Yeah, go ahead.
Well, you're too kind. So hi, everybody, and sincere apologies for the technical snafus. I turned 47 last month, so I've now become one of the consultants who needs his junior staff around to make his technology work. Christina Fleming is sitting over there in Bordeaux, laughing her over-wined and over-cheesed posterior off and texting me all the way through it. I can understand the text, Christina, but I can't make the computer work. So hi, everybody, and thanks, Dermot, for the invitation. Dermot's asked me to speak a bit about the use of the robot in the complex ventral hernia, so those whoppers, the 10 centimeter and greater ventral defects that unfortunately we have far too many of. We started our robotic hernia program a few years ago here in the Matter. Obviously, things have been on a bit of a hiatus for the last couple of years, although when Christina was working with us last year, we managed to get a few of our robotic transversus abdominis release, our RoboTAR repairs done to add to our experience, and a few of the caveats to begin with. The first thing to say is I'm a late convert to the robot. I was not a huge fan of it to begin with. Being a conceited laparoscopic bariatric surgeon, I didn't need the robot. I can stitch. Why would I need 2.5 million worth of equipment? Over time, my opinion has softened a bit on this. And I think there are certain things that the robot for general surgeons may be the killer app for, particularly as the number of platforms available to us becomes greater. Can you see my slide screen there? Or is it still just me?
No, we can see it. Thanks, John.
Great. So I'm as I said, a late convert to the robot, and I won't get into the chapter and verse and there's a lot of single center and even multi-center data coming out now on the use of the robot for straightforward hernias, for groin hernias, for ventral hernias, and for the bigger, more challenging ones. I won't get into that for the purposes of time, but the questions that always come up are, why should we be using the robot for this? Isn't a lot of the laparoscopic repair work that we're doing very good? And for the real huge ones, surely a minimally invasive approach isn't going to work. We should be doing something composite or one of the more complex lateral release, component separation, bioprosthetic meshes, etc., etc. The usual answers trotted out for why we use the robot are the usual suspects when it comes to the robot. It's much less invasive. There's less pain, even compared to laparoscopy. The dexterity, the position, and there's no question but that in the scenario of the improved view and the enhanced dexterity of the robot, these are definite enormous advantages to the surgeon in approaching the ventral hernia. It simply makes no sense in many respects, and I do lots of laparoscopic hernia repairs, that you're putting a straight stick camera perpendicularly through the abdominal wall, then turning around to look backwards up at the anterior abdominal wall, and doing the same with your instruments. And the problem with laparoscopy all along has been the dearth of really good instruments now. So that the robot adds a huge amount here in terms of our the facility of actually doing something meaningful laparoscopically or minimally invasively, and the different types of repair vary in complexity, but they allow you to place extraperitoneal meshes and to cover a pretty broad area and provide a very impressive biomechanical reinforcement to a fairly damaged abdominal wall. We started at the simpler end of the spectrum with the transversus abdominal release. We haven't got into the more complex version where you tend to spread the mesh even further. This is a diagram from Philip Wiesums, who'd be one of the doyens of laparoscopic ventral hernia repair. And while while we're all very familiar with the IPOM underlays and the various different efforts at composite and retromuscular open repairs, with the RoboTar and RoboTar-Up, you can get way out beyond the standard lateral margin of the rectus muscle. The pitfall, of course, being running into the neurovascular bundle that appears between internal oblique and the transversus. But we're working on the TAR space, which is out as far as the linea semilunaris. And intuitively, when you sit at the robotic platform, when you look at the plane you're developing, and I'll show you some video momentarily, you know this makes sense. I've been very slow to accept that the robot is definitely better than good laparoscopy or good open surgery in some respects, many respects, but there are some things that it's definitely better for. The minute I sat at the console at the first one of these, the first course we did in Paris with Philip Wiesums in 2018, it immediately hit both myself and Connor Shields, who went to do the course with Intuitive. This is good. This is a really sensible biomechanical approach to this, but it's not easy. And Christina will attest to that, having watched me curse and swear my way through a few hernias in the last couple of years. The questions as to why you mightn't use the robot are, again, the same old chestnuts. It's not everybody's got a robot, and if you do have a robot, which robot should you be using? We were in the unique position in Ireland of having one of the greatest density per capita of robots in the world. We've been massively outstripped, and interestingly, Intuitive had their biggest sales year ever last year. During the height of the pandemic, they sold something like 11 or 14,000 platforms worldwide. So people have caught up with the preponderance of things we had here. Again, as Christina will attest, and is becoming a recurring issue for trainees, how do you get trained on this? How do you get trained on this as an established surgeon? I was nearly 4 years in practice before I started into this, and it's hard to get time on the robot. Plus, it's also hard to get your institution to say, okay, we're going to do ventral hernia repairs with the robot. Sure, you can do a prostate. Sure, maybe you can do some pelvic gynecological work, but other things, we've been very lucky here in the Matter Party political broadcast for Eccles Street. We've been allowed to use the robot very, very broadly, and so we've developed quite an experience with it. But been very encouraged to use it for ventral hernias, because actually a ventral hernia repair done robotically in our institution is about €1,000 cheaper than a laparoscopic repair, because we're using a very, very, very cheap mesh. You can use a big flat sheet of Prolene in the retrorectus extraperitoneal space, and so, notwithstanding the fact that they're slow because we're still early in our learning curve, these can be done much more cheaply than the standard laparoscopic repair. The patients are all placed supine. We approach from either right or left, and the newer XI platform is terrific for this in terms of its flexibility. It's much easier to position as to dock it, and in general, it's for the non-pelvic surgeon. I think the XI has been a terrific addition. So we'll jump straight into the videos, and this is warts and all video. Okay, this is unedited. This is from we're still relatively early in our experience, and as I said, intuitively, I think this is a great idea. I think it's a terrific way to repair hernias, but they're incredibly frustrating because we're not slick at them yet by any means. So this is the view you get. You're getting a. Can you see the video playing there, top left?
No, video's not playing.
Okay, one sec. I'll try and
you may need to go to slideshow, John.
I think I might have it there now, am I?
Yeah, well done.
Great. So that's the view of the anterior abdominal wall from the patient's left. And you're very far left when you put these ports in. And we're looking at the lateralmost portion of the posterior aspect of the rectus. And with the grasper on the left, I'm trying to pull down the posterior portion of the sheath. And I'll speed this up for the purposes of time. To make an initial incision in the sheath, and then to develop that retrorectus plane. So again, this is, you know, we're off the beaten track here compared to what we normally do with an IPOM. Once you've got your hernia reduced with an IPOM, you're just, you know, positioning your mesh and getting in place. And when you're 2.5, 3 hours into your second, third, or fourth robo tire, you're wondering, geez, you know, is a bit of Simbotex here all that bad a thing? But I think it's worth persisting with, and we're trying to do, well, I suppose when things settle down next year again, we'll try to do more. So you can see you get into that nice angel hair plane. You're behind the sheath, and the muscle will lift up in front of you, and the pneumoperitoneum helps brilliantly here. A lot of these patients, as we all know, have a fairly significant level of diastasis. Their recti are very far apart in the midline. That actually helps here, because the abdomen will distend up really, really well like a balloon, and it pulls the muscle up and away from the sheath for you. And for the first 30, 45 minutes, you're thinking, I'm awesome. This is fantastic. I'm flying through here, making wonderful progress. And then you get here, the linea alba. Once you get to the midline, this is where the rubber starts to meet the road in relation to doing this hernia repair, these types of hernia repairs. And having done the course with Philip Neesom's, when you see the guys who are good and girls who are good at this, I might add, you're going, wow, this is really impressive. And then you get to the linea alba yourself on your own cases, and this is really challenging. It gets very difficult here because the linea alba is quite stretched. While you get to the medial portion of or medial margin of the rectus, you think this is great. But then once you traverse the midline, you can see there, as I'm lifting up and down the flap, the defect is not far off us here. And to be sure that you're giving yourself as much of the fascia and the peritoneum so that you can cover your defect once the mesh is in, or indeed if you put the linea alba back together, you will make the mistake that I make fairly regularly, and that is to get anterior to the contralateral muscle belly. This is a really difficult part of it. This is kind of the sticking part, or the sticking point for robotic transversus abdominis plane repairs. And as I said, warts and all, I'm not at a point where I think where I've got this anywhere close to mastered yet. So it's challenging, but I think it's worthwhile, and you'll see, and I hopefully you'll see why in a second. So if I want to show the next video, that's this one, I think. Wrong one. Apologies, bear with me. So these are slow; they don't happen quickly, but once you've got your plane done, and you've crossed the linea alba, so we're now over onto the other side, behind the other belly of rectus, across the midline. The issue you're going to face then is dealing with the sac that's going up, often subdermal, it's our subcutaneous, it's pretty tenuously linked to the skin, and the question becomes, what do you do here? Again, as your experience grows, you get a bit more comfortable with these things, and certainly my approach to these is to amputate the sac without compromising the skin. Early on in our experience, we buttonholed the skin on one of the patients because it got to the wrong side of the rectus, didn't realize it, and the next thing you knew, I had a very bright view at the end of my scope because I was looking through the skin. So this is by no means an easy repair, and it would be inappropriate for me to say that this is only be done by certain surgeons in certain centers. I don't think that's the case at all, but it does take the learning curve on this is very significant. We have a very big experience of laparoscopic incisional hernia repair, and of all degrees of complexity. So we're by no means neophytes, but this is difficult, worthwhile, I think, but difficult. And the reason it's worthwhile is you get to the point where you can put in a pretty sizable mesh and a very cheap mesh, which is for sure a boon in this day and age. And it's a little bit fiddly getting the mesh opened out into the appropriate plane. You roll it up like a double cigar and stitch it together, and it's put down as a double-barreled cylinder through one of your operating ports, or indeed if you're putting in a big mesh as we were in here. This was a 20 by 30 to cover a fairly sizable defect. Through your assistant port, which is what we use our air seal port as our assistant port, and then you just flatten it out into that pre-peritoneal retrorectus space. We use 4 corner stitches for transfascial fixation, and you can get very high up. You can go right from the costal margin all the way down to the pubic to the pelvic brim if you need, and anchoring it in place is relatively straightforward. What I haven't shown here is my attempt at linea alba closure, because I'm struggling. To be honest, I'm struggling with it. I was never a fan of V-lock sutures, and I'm demonstrating very clearly over and over and over again why I'm not particularly fond of V-locks. They tend to snap, certainly in my hands, and I don't have good video yet to show a really slick bit of suturing closing the linea alba. I typically use 4 or 5 V-locks, where Philip Muysons will do it with 1 from above and 1 from below. And apropos of which, here I am about to snap a V-lock while closing the flap. So what has happened prior to this is the mesh has been flattened in the retrorectus space. There I go, snapping it. And it covers the entire area of the defect and overlaps very significantly. It does this all extraperitoneally, extra rectus, and the repair is very robust. With the linea alba closure, it's even more robust, and these patients are significantly less sore postoperatively than they are even with a straightforward laparoscopic underlay repair, because there's no tacking. There really is only the 4 transfascial sutures with a bit of tension. And otherwise you've just got 3 8 millimeter ports out in the patient's flank. So I know we're short on time, and for the purposes of getting on with the questions, I'll hand you back over to Dermot. But so I suppose the bottom line here is Robotar, I think, is a really, really excellent potential technology for ventral hernia repair. What it isn't is easy, and what it shouldn't be is done by everybody until such a time as we have a fairly decent approach to how we train this, because training at the moment, even at especially at consultant grade, is very haphazard. If you're in Christina's boots, a well-trained senior surgeon now on fellowship in a robotic unit in France, this is the kind of person who should be coming back and I think leading the charge for our robotic hernia repairs going forward. So apologies for the technical snafus, and thanks again, Dermot.
Thank you very much, John. I think we've run very short of time, but I think it was well worth it. 2 things come to mind. First, Ken Mealy has quite, as Ken always does, he has come up with a very valuable suggestion here as to perhaps, bearing in mind that we really do need a registry, and going forward we will have to have a registry. And from listening to Christina, she's going to be able to utilize that registry to a maximum. Should we be in a position perhaps to contribute some of our educational fund into supporting the registry along the way? That is a possibility, and if appropriate CPD time was applied to that, and we could always do that. We're a good bunch of people who can work together when we want. I think that would be a great idea. And the second thing is our Surgical Research Collaborative is really a very valuable group of people, and perhaps as our colleagues in the United Kingdom have done, perhaps the RCSI might be able to see to supporting a fellow with a grant or something like that to contribute some research from the registry. I think it might be a good idea. Professor O'Connell, would you like to wrap up, make any comment before we go? I know
well, Dermot, I'm looking for the key to the coffers of the college immediately. I've never had a more direct plea. But I mean, you will be pleased to know that we've appointed a director of national research and also a research manager to support what the Research Collaborative have been doing, and to provide a network across the country out with RCSI University, but this is for the surgical community across the country. So, I mean, we are actually making considerable strides in that regard. I don't know if there is an Irish Hernia Society, or whether or not a branch of the British Hernia Society should be established here. And most of these UK and Ireland societies have been GB&I, and it would be nice to have an all-Ireland component to it. But I understand that once you've got the British Hernia Society, it'll be difficult to change the name. But that would be one way of looking at it. I think we've had an interesting evening. I certainly think that if you don't know the data, if you don't know the outcomes, you can't make changes. And it's only when people know their data and see how they benchmark do they change. And I quite agree, people should not be doing very complex abdominal wall hernias on the occasional basis, in the same way as they shouldn't be doing complex anything on an occasional basis. And so Sean, you'll be pleased to get loads of referrals, I would say, of these nasty recurrent hernias that have failed to survive the repair efforts in the matter. They'll be down to Tullamore. But John, thank you for that. I mean, it does beg the question, and I'm sure you've addressed it in part. I mean, the learning curve of these is vast, and the only way you could justify doing it is because you've got vast experience of doing it laparoscopically and are familiar with it. But this is not this is not a procedure for anybody who's got a robot access and they're not very experienced in this. I mean, you could see the difficulties of it. One thing that occurred to me was, without the fixation, that mesh tends to, with fibrotic ingrowth, tends to curl up and to contract. And so that I just put one question to you: is that not an issue if you're not fixing it in the way that you would normally do?
Yeah, it's certainly one of the concerns. The thing, I suppose, the thing about it is that the different pore sizes on the polypropylene meshes now are purported to allow much less of the fibroblast mediated mesh contraction that we've seen historically, and same with the groin meshes, with I suppose with mesh technology in general. The proponents of this say that because of that they're not encountering it to that great extent. I think there's less tenacious fibrosis because they're extraperitoneal. But you know, we've really only been doing these now since 2018. Our experience isn't big enough yet to say, and nobody has been doing them for a very long time. So much like everything else, time will tell in all of these things. The biomechanics of this make great sense. And when you're looking at it, when you're placing the mesh, it goes, and when you're using the robot to do it, your capacity to dissect and to cover bigger space is really, really far greater than what it is with laparoscopy, and I'd be an enormous proponent of the laparoscopic approach. So I really think there's something to it. I'm not the virtuoso at it that the hernia surgeons around Europe are. There certainly should be people doing this as their main interest. And particularly, I suppose, as the past year and a half have taught us an awful lot of things. There are some hospitals that we should be doing certain kind of work, and other hospitals that should be doing other kind of work. And this is something that maybe doesn't need to be in the Model 4 hospital, but certainly does need to be in a Model 4 surgeon's hands. So I think there's great merit in it, but like everything else, the learning curve is tough.
Well, now you've opened a hornet's nest there, a Model 4 surgeon's hands. With that, I will wait for the detonation, and I will end the webinar this evening. And thank you all very much, Liam particularly for joining us, Dermot for organising it, Sean, Christina, and John for presenting. And as always, my thanks to the Vice President Laura Vianney, who arranges the programme, and to the backroom team, Catherine, Jordan and colleagues, and Porrick, Kelly and all the colleagues in Surgical Affairs, who put a lot of effort into getting this to run smoothly. So good evening and thank you very much.